So it really gives me great pleasure and privilege to be able to introduce Dr. Andy Levy to you. Dr. Levy is a professor of medicine at the Gerald and Dorothy Friedman Professor Emeritus at Tufts University in Boston. And he's really been, as you know, a leader in the field of our understanding about kidney diseases. He's been interested in measurement and estimation of kidney function, the epidemiology of chronic kidney diseases. And I had the privilege of first meeting him and working with him on the original KDIGO classification of kidney disease, which is way too long ago for me to actually remind anybody what year it was. But he's widely recognized and has won numerous awards, including the Belding-Scribner Award in 2013 at the ASN. He really is a giant in the field of estimation and kidney function, and in the before times he would have been here visiting. We would have had great conversations around the table with the fellows and a nice dinner, but instead we get a Friday morning breakfast and learn with him. So I'm going to ask Andy to go forward in one moment after I just give the territorial welcome, which is to acknowledge that I am sitting and hosting this session on the unceded and ancestral territory of the Coast Salish peoples that include the territories of the Musqueam, Squamish, and Tsleil-Waututh nations, and the Métis Charter Community of the Lower Mainland region. And you are all in your various territories and regions around this province. And I want to take a minute to acknowledge and for you to think about where you are. Next slide. So these are the learning objectives that Dr. Levy provided for us. And without much ado, I'm going to actually hand it over to him. Please do feel free to put your questions in the Q&A box, and we will have some time at the end for that. So over to you, Dr. Levy.
Well, thank you, Adira. It's really a pleasure to spend this time with you. It's much easier to travel to British Columbia than this way than it is to actually fly there, but it's not nearly as much fun. But I do appreciate that I can potentially reach more people through the Zoom because fewer people are able to attend conferences in person than by Zoom. I will start to share my screen, and forgive me if this takes a moment. I get the message that you need to stop sharing your screen for me to share mine. Okay, great. Let's see.
There you go. It's working.
You can see the screen? I'm going to try and move it to a different place so I can see it better. All right, and now it's on presentation view?
Yep.
Okay. So here are my disclosures. And I'll be reporting today on two consensus conferences hosted by KDIGO. The first was a nomenclature conference, and the second was a harmonization conference for the definitions of acute and chronic kidney disease. And okay, so the first of the two conferences was held in Amsterdam back in June of 2019. And here is a picture of the participants. And I want to point out that Dr. Levin was in this meeting. Kai Eckhart and I were co-chairs of the meeting, along with Naisha Dorman, who's the managing editor for AJKD, and Stacy Christensen, who's one of the managing editors for JAMA and directs the AMA Manual of Style. And you'll see a number of editors in the audience here. Here's Raj Malhotra from CJASN, Josie Briggs from JASN, Julie Engelfinger from the New England Journal of Medicine, Harv Feldman from AJKD, Pierre Ranco from Kidney International. So we actually had the renal editors that we wanted to be at this conference, because this conference was all about terminology for medical publications. The paper's been published already, came out in KI with all of the editors as authors of the paper. And because this has been out already and you may have had a chance to see it already, I'll actually spend a little less time on this than on the other conference. The other conference was on harmonization, and it was to be held in Toronto, but instead here's our group picture. Okay, this is becoming more and more common these days, so it wasn't nearly as much fun. None of us look quite as good as we do when we smile in person. Dero was one of the main organizers, John Kellum, Paul Stevens, and I don't think I have a picture of Norbert Lemire.
Yeah, he's on the corner.
So the goals for the presentation are to first explain the rationale and the disclaimers that are relevant to that. What were the goals of the conferences and the main questions to answer? We'll start with nomenclature, talk briefly about patient-centeredness and precision, spend more time talking about the KDIGO definitions and classifications, a little bit of time, a little bit of data actually regarding the AKD definition and risk associations, and then talk about the glossary. And our goal is to be something more important than just be the grammar police of nephrology publications and nephrology speak. And I think that this information won't change your practice all that much. This will not change nephrology practice. What we hope to do is to improve the communications between we nephrologists and people who take care of kidney disease more often than we do, actually. The earlier stages of kidney disease, and particularly acute kidney disease, which are hospitalists, primary care physicians, general practitioners, and people in other surgeries. So this will affect the language, hopefully, but I think you'll see that it doesn't change that much of what you do. So by way of background, what we're really trying to do is to recognize a health disorder and to create optimal health outcomes. And along the way, we need to diagnose the health disorder, classify it, and treat it. And we need to be able to communicate our efforts among ourselves as physicians and also with patients and other interested people. And of course, nomenclature is key to this. There's a famous article called Chronic Renal Confusion, which was actually published in 2000 before the guidelines that Dr. Levin didn't want to remember were published in 2002. And although they discuss the state of difficult terminology, and there has been much progress since then, but there's still limited consistency, there's still imprecision, and there's still lack of patient-centeredness in our nomenclature. We think that improving nomenclature will require involvement of all stakeholders, consensus among us, and willingness of scientific medical journals. So these were the introductory slides that Dr. Eckhart presented at the conference in Amsterdam in June of last year. So why is uniform nomenclature important? It facilitates communication between healthcare provider and patient, takes into account patient preferences, minimizes language ambiguity, mobilizes self-management and advocacy. And for clinicians and health professionals, it can reduce confusion and errors in practice, promotes consistency in research, design, execution, communication, and it raises public awareness. We think these are worthy goals. The guiding principles in the effort from the nomenclature conference and for the glossary that was published as a result is to use patient-centered terms. So the wording should not be demoralizing or stigmatizing. To use precise terms, the wording should foster accurate communication in practice, research, and public health. and the term should be consistent with the KDIGO guidelines. The adoption and definition of wording should aid evidence-based practice and guideline implementation. So the goals of the Nomenclature Conference were to revise and refine nomenclature to describe kidney function and disease. And we wanted to focus on general descriptions of acute and chronic kidney disease and general kidney measures, rather than specific kidney diseases and specific measures of function and structure. The principles were that it should be patient-centered, precise, and consistent with the guidelines. And think in terms of these 5 bullets. As far as being patient-centered, we thought that it would be best if most terms used kidney rather than renal or nephro. That end stage was replaced with a less stigmatizing term, failure, although failure can be stigmatizing as well. That we should use the CKD and AKI definitions and stages in KDIGO guidelines versus other descriptions of disease and disease severity. That we should use specific kidney measures such as GFR or measures of tubular function and markers of damage and injury versus non-specific terms such as kidney function. And we thought this would aid guideline implementation. And by the end of the conference, our goal was to answer these questions. Do you agree that articles in English language medical literature should generally use kidney rather than renal or nephro? Use kidney failure with appropriate descriptions or presence of absence of symptoms, signs, and treatment rather than end stage? To use the KDIGO definitions for AKD and AKI and CKD rather than alternative definitions, and that specific kidney measures should be used rather than general terms. And by the end of the conference, we had a widespread consensus on each of these 5 things. So we went ahead and produced and disseminated the glossary that I'll talk about a little later. Out of scope were the following: a new classification of disease, terms related to dialysis procedures, adequacy, performance measurements, or outcome measurements, regarding dialysis vascular and peritoneal access procedures, or transplant procedures. It's not that these aren't important. We thought it was just preferable to start with more general terms. So we had a number of presentations. Stacy Christensen talked to us about the AMA Manual of Style. The 11th edition came out right as we were having our conference, and she told us in the 10th edition there was no mention of nomenclature for kidney disease, not a word in the style. But in the 11th edition, it would be acknowledged that KDIGO was spearheading an international effort to revise the nomenclature. It was acknowledged that the 11th edition says the effort will focus on making terminology more patient-centered and precise. And the final recommendations and the complete glossary of terms will be available after the conference. So we know the AMA Manual of Style is being updated with our KDIGO glossary. We think this is a big advance. We had a presentation from Allison Tong on patient and caregiver perspectives. This work has now been published. She conducted a series of focus groups in order to determine patient and caregiver perspective. It's been published in CJASN, along with an editorial by Julie Engelfinger and a patient perspective by Paul Conway. And the results of the survey merely highlighted a number of themes which dealt with a lot of discomfort that patients had with our current terms. We had a presentation on precision medicine from Matthias Kretzler. He's one of the principal investigators for the NIDDK, that's the US kidney medicine, precision medicine project. And he really spoke to us about how a new lexicon will develop with the advances in precision medicine, but rather than replace our current terms, this will simply build on our current terms, much the way the new lexicon for oncology has not replaced the TNM system. And then we had a survey done by Naisha Dorman regarding the attitudes towards kidney health, kidney-related nomenclature. And this was a survey of the attendees, the public comments regarding the conference, and some Google Scholar searches. And she concluded that the prevailing attitudes from these surveys was that there was agreement with the goal of standardizing nomenclature with acknowledgement of the challenges. There was a qualified endorsement for replacing renal with kidney. There was dissatisfaction with the term end stage, and there was recognition of the need for ongoing attention to nomenclature issues. So that's a brief summary of the conference and the conclusions. I'll have some more detailed comments about the glossary and hope that we'll have enough time. I did want to spend more time on harmonizing the definitions of acute and chronic kidney disease, and so we'll turn to that next. Now, the conference objectives were to revisit and refine the definition of acute kidney disease that was suggested in the 2012 AKI guideline, and describe the relationships between this new term, acute kidney disease, with the established terms AKI and CKD. And we have some original data analysis using additional cohorts that were presented at the conference. And I'll go through that presentation. What the conference would not do would be writing a new guideline or revising the KDIGO AKI guidelines. We'll not be writing graded recommendation statements or practice points, and we'll not be revising the current KDIGO definitions of AKI or CKD. So the goal was simply to put forth an AKD definition and classification that harmonized with the existing recommendations. Now, the existing guidelines do define and classify CKD. They do define and classify AKI, and they suggest the definition of AKD, which we call acute kidney diseases and disorders. Now, I think what stimulated this is that the 16th ADKI conference proposed an alternative definition of AKD. And there's actually been a lot of confusion in the current writing as to what AKD means, because people are starting to use it more. And credit goes to ADKI 16 for picking it up, but it's was not completely helpful that they came to an alternative definition. So it's even more important that this be harmonized now. The current KDIGO guidelines do not define recovery or resolution of AKI, but ADKI 16 does, and I think this is an advance. And I think when the AKI guidelines are updated in the future, and they will be, this will be included, but we didn't define this. ADKI classifies AKD. The guidelines do not, by the way, define kidney diseases and disorders, right? All of these, CKD, AKD, AKI, must be a part of kidney disease. And by the same token, there is no acknowledgement that we can ascertain that someone at the current time has no known kidney disease or disorders, which I've abbreviated NKD just for consistency. So my thoughts, what a disease definition should include. It should include a conceptual model. It should include a definition in words in English. And most important, it should include the criteria for meeting the definition. So some definitions of definitions. So Wikipedia, which is now my go-to authoritative source, but I've looked up these terms in Oxford as well, and these are consistent. Defines a disease as an abnormal condition, right, that negatively affects structure or function of all or part of an organism, not due to an immediate external injury. A disorder is a functional abnormality or a disturbance, and presumably it's part of the abnormal condition, but it doesn't say. Acute and chronic are terms that relate to duration, not severity. Okay? Acute meaning short duration and recent onset, chronic meaning persistent, long-lasting. So we'll use these kinds of terms. Classification in kidney disease. After the guidelines came out, the guidelines that Dr. Levin chaired for CKD in 2012 and that Dr. Kellum chaired for AKI in 2011, we put together this little diagram for the elements of classification. Classification can be by structure, by function, by outcome, by cause, and by duration, as we've just seen. And we neglected to include by treatment and response, right? And in discussing AKD as distinct from CKD, right, we're really talking about duration. So why is it important to define and classify AKD? It's because some patients with kidney disease and disorders do not fulfill the criteria for AKI or CKD, yet they require medical attention. Without a definition for AKD, there's a gap between AKI and CKD, which is conceptually illogical, leaves patients in a gray area without a valid label and without management recommendations. Again, this isn't something that we nephrologists don't understand, but this is in terms of the guidelines for widespread dissemination across all medical specialties. And this is taken from the scope document for the conference. Now, here's some examples of acute kidney diseases and disorders that do not fulfill the criteria for AKI. So they include decreased kidney perfusion, as occurs commonly here, parenchymal diseases, and obstructions, unilateral, usually as a stone or a tumor, but they don't fulfill the definition for AKI if they occur without or before sufficient GFR decline to fulfill the criteria. That is, the GFR decline is too slow or too small, right? Remember, for AKI, the creatinine has to increase by 0.3 within 48 hours, 0.3 milligrams per deciliter, or rise by 50% within 7 days. So if these diseases occur, but the GFR decline is too slow or not severe enough to fulfill that definition, they're not called AKI. And of course, this can occur. We recognize that people present with nephrotic syndrome with no change in GFR, with pyelonephritis with very little change in GFR, unilateral obstruction with little change in GFR, and we wouldn't want anyone to not take care of these patients because they don't fulfill the criteria for AKI. And if it hasn't been for 3 months, they don't fulfill the criteria for CKD. Now, also note that all of these disease conditions can be superimposed upon CKD due to something else. So the goal is to recognize these conditions and take care of them, even though they don't fulfill the labels for CKD and AKI. Now, to describe them, we would say that some of these are characterized by markers of kidney damage, such as proteinuria, urine sediment, imaging abnormalities, or even a biopsy. But others are characterized only by decreased GFR, such as some of these. And here's the only data that I'll be presenting, and it's from the Alberta Kidney Disease Registry, so not so far away. And they took the criteria that were written in the AKI guideline that contrasted the criteria for AKI and CKD and proposed these criteria for AKD. So here's the AKI criteria, functional criteria only, no structural criteria for AKI. For CKD, functional criteria based on GFR, structural criteria inferred from markers of kidney damage, but for 3 months. AKI again, within oliguria within 6 hours, rise in creatinine by 0.3 within 2 days, or 50% within 7 days. And we said that AKD could be AKI, meaning any of these criteria, or a GFR less than 60 for less than 3 months, a decrease in GFR by 35%, or an increase in serum creatinine by 50% for less than 3 months, or kidney damage for less than 3 months. So you can see that this is an amalgamation of criteria taken from here. And then no kidney disease would be if you didn't have any of these things, meaning GFR greater than 60, stable serum creatinine, and no damage. And the first author and his team, which I was pleased to participate with, simply looked at their registry and created a cohort in which they could ascertain these conditions, look at their relative frequency and their outcomes. And this graph shows the relative frequency in 2 cohorts. Residents who had creatinine tests or kidney tests in 2008, and then their frequency for residents in the census, because not everyone in the census had these tests. And you can see that the most common condition was CKD, occurring in 10% of residents tested. AKD was second most, almost 4%, AKI 1.5%, AKD superimposed on CKD 0.5%, and AKI superimposed on CKD about the same. And expressed for residents in the census, you can see it's 4%, 1.5%, and less than 1% each. So AKD is not as common as CKD, but it's about 3 times more common than AKI. Now, what about the prognosis? So this probably looks small on your screen. So this graph has mortality as the outcome, and these are cumulative incidence curves. And this is follow-up time from the initial ascertainment in 2008 with up to 8 years of follow-up. This is CKD development. This means people did not have CKD to start with, but developed CKD later. CKD progression, so these people had CKD to begin with, but it got worse later. And this is end-stage kidney disease or kidney failure treated with replacement therapy, the way the glossary would have us define it. NKD, meaning no kidney disease, is the most common, right? So these are people who didn't have anything to start with, right? Excuse me, this is the NKD curve, excuse me, and this shows the least frequent development of mortality, least frequent development of CKD, progression of CKD not relevant because they didn't have it to start with, and least frequent development of ESRD. So the NKD is really the reference group or the control group. CKD and AKD are here for mortality, right? About 0.3%, and AKD just as much as CKD. The combination of CKD or AKD superimposed on CKD is about the same as AKI, and the worst prognostic factor is CKD and AKI. So AKD is pretty important, as important in predicting mortality as CKD. Regarding developing CKD, AKD is clearly the most important. Now, maybe this is CKD that's first recognized, although they tried to avoid those cases in the rules. But I don't think that's a bad thing because it's important to recognize CKD. And if you recognize it for the first time and you're not sure whether it's acute or chronic, it's important to treat it. As far as CKD progression, AKD superimposed on CKD was even more important than AKI. And regarding end-stage kidney disease, AKD was just a little bit less prognostic than AKI. So there's no doubt that AKD is common and that it's associated with bad outcomes. It's harmful. So if we accept that AKD needs to be in our lexicon of definitions, let's see how it fits into a proposed conceptual model for the continuum of acute and chronic kidney disease, which includes AKI. So this arrow, right, just shows the chronicity of kidney disease. And we would say that when kidney disease is first recognized, right, and if it hasn't been there before, we'll call it acute. And if it persists for 3 months, it becomes chronic, right? So the difference between AKD and CKD is just merely one of duration. Now, AKD may start with an AKI episode. This is the ADKI representation. And if it doesn't get better, you're left with AKD. But it's clear from the work by James et al. That AKD could start without an AKI episode and become CKD, or the AKI episode could come later, or it could be realized later. Right? So we view AKI as a sudden, a disease of sudden onset within 6 hours to 7 days, okay, which can initiate AKD or be superimposed upon AKD. Remember, AKI is a subgroup of AKD, right? So once you start with AKI, by definition, you have AKD. And of course, AKD or AKI could occur anytime in the time course of CKD. So this is our conceptual model. Now, in terms of definition in words, I'll go through these slides quickly. Chronic kidney disease in the guidelines is defined as abnormalities of kidney structure or function for greater than 3 months with implications for health. So we would propose that we define a term for kidney disease where we just take out the chronicity component. Kidney disease is defined as abnormalities of kidney structure or function with implications for health. And then acute kidney diseases and disorders, notice this is plural and we've added disorders, are defined as abnormalities of kidney structure or function for less than 3 months with implications for health. Acute kidney injury then could be described as a subgroup of AKD, defined by alterations in kidney function over 6 hours to 1 week with a duration of less than 3 months. And AKD without AKI would be the subgroup of AKD in which the alteration in kidney function is not as severe as in AKI. So these are the proposals from the harmonization group. And then NKD would be defined as no structural or functional alteration of the kidneys as ascertained by not fulfilling the criteria for AKD with or without AKI or CKD. Now, this doesn't mean that if you don't have these criteria that you don't have anything the matter with your kidneys. It just means that within the limits of our typical ascertainment, right, that you don't meet any of the criteria for acute or chronic kidney disease, which includes AKI as part of AKD. So as a summary slide, it would look something like this, with the duration at 3 months, AKD moving to CKD if it's progressive, episodes of AKI during AKD, episodes of AKD or AKI during CKD, and these definitions that I just talked about. And then this would be the overlap. Any single patient could have AKD, could have AKI. If they have AKI, they have AKD. A person could have CKD. A person could have CKD and an episode of AKI superimposed, or the person could have CKD with an episode of AKD without AKI superimposed. And all around, of course, this would be NKD. Now, turning back to a conceptual model of how to harmonize the conceptual models for kidney disease, here's what we have for CKD from the KDIGO guidelines. Here's what we have for AKI from the KDIGO guidelines, specifically designed to be very similar to the CKD model, but a little more verbiage. And here's something that was proposed by Eckhart et al. In the Lancet in 2013 for a model for kidney disease, but has not been adopted into KDIGO because we don't have a definition for kidney disease until this harmonization conference. And it combines elements from both the acute and chronic disease model, and it simply states that duration of less than 3 months is acute, greater than 3 months is chronic, and this area here represents AKI because there's no markers of damage. It's a decreased GFR or kidney failure. So we would propose that this become the KDIGO conceptual model of kidney disease. Now let's talk a little bit more about the criteria for AKD. The structural criteria would include markers for kidney damage. The functional criteria would include changes in serum creatinine or GFR. Now the markers of kidney damage in CKD, this is a slide I always show, includes albuminuria, urine sediment abnormalities that are due to kidney diseases, electrolyte or other abnormalities due to tubular disorders, pathologic abnormalities, imaging abnormalities, or a history of kidney transplantation. Many of these are relevant for AKD. I've crossed off the ones that don't seem like they're relevant to an acute disease, right? But we're left with a large number of markers of kidney damage, which makes sense to us. Now, what about creatinine and GFR? This slide, you all know well. We teach this to our students. During an acute GFR decline, endogenous filtration markers rise, right, until they reach a new steady state. And in the new steady state, our estimating equations work fairly well to estimate the GFR from the marker. And you can see that as days go on, from day 0 to day 3, the marker rises. Initially, the estimated GFR is misleading, okay, but it approaches the true GFR as we get into the steady state. So there's the reciprocal relationship with MGFR in the steady state, but eGFR is less accurate in the non-steady state. It's not that it's totally inaccurate, it's just less accurate, and it becomes more accurate as time goes on. So in summary, whereas decreased GFR is a criteria for CKD, and usually ascertained as eGFR, rising serum creatinine is the criteria for AKI, although neither serum creatinine nor eGFR are in the steady state during AKI. And since AKD has a slower rise or slower decline in GFR, it seems more reasonable that we could use eGFR in addition to the serum creatinine decline. So both decreased GFR and a rising serum creatinine are included in the criteria for AKD. And these are the criteria then. And this is exactly what I went through for the James slide. Okay? Criteria for AKI include functional criteria only, no structural criteria. Criteria for AKD, it includes AKI or GFR criteria, less than 60, a decrease in GFR, an increase in serum creatinine, but without the time criteria, and markers of kidney damage. CKD criteria are unchanged, and NKD meaning none of the above. There's some related questions for nomenclature nerds like me to try and ponder. For should we use singular or plural for chronic kidney disease, because we use plural for acute kidney disease? Should we add disorder to CKD? Everyone who's been upset that we're mislabeling people with disease might prefer to have it called chronic kidney diseases or disorders. Now, regarding the staging, I'll try and be brief here. We have staging of CKD. We have staging of AKI. Staging for CKD is based on cause, GFR category, and albuminuria, known as CGA criteria. And we have staging for AKI. It's based on the severity. And it also says cause should be determined. So here's our CGA classification for CKD, and here are our AKI stages. AKI staging doesn't include cause, although it acknowledges that cause is important. And here's the proposal for AKD classification. Cause would be included, and the next thing would be to determine whether AKI is present. If AKI is present, then we would use the AKI staging. If AKI is absent, we can't use the AKI staging. So if there's AKD without AKI, we would use the GFR and the albuminuria staging as for CKD. And if AKD persists after AKI resolves, then we would also use the GFR and the albuminuria categories as for CKD. So this is the proposal from the conference. I think it's the simplest thing we could do other than not staging it at all, and people were uncomfortable with not having any staging. So regarding the glossary for kidney function and disease, the glossary has not been updated with the staging for AKD, but it had in it the criteria for AKD. The strengths of the glossary are that it's based on existing KDIGO definitions, classifications, and nomenclature. It's based on a systematic process, articulation of a rationale, goals, patient and attendee survey, and attendee consensus. And it acknowledges that nomenclature standardization is a necessary step, but not the only step to improving communication. Limitations of the glossary is that it's restricted to English. Nuances may be difficult to translate to other languages. For example, in Romance languages, there's no need to translate renal into kidney, right? Renal is the term, right? In Greek, there's no need to transplant nephro into kidney. Nephro is the term. So this is restricted to English, but I will tell you that different groups are starting to translate the glossary. Dr. Eckhart is leading a initiative in Germany to translate it. Now, the stakeholder limitation or participation was limited by practicality. We had about 50 people at the conference, but we didn't have everyone. It's not comprehensive. Several topics were out of scope, and further specification may be required for studies in children. The way the glossary looks is there are 5 parts. Part 1 has to do with kidney function and disease, but for each part there's a preferred term, suggested abbreviations, a brief rationale and explanation, and a list of terms to avoid. So for part 1, general terms for kidney function and disease, it says kidney should be used preferentially when describing kidney disease and kidney function with exceptions. Terms to avoid would be renal, the prefix nephro, except in the setting of specific functions, diseases, or syndromes. For example, membranous nephropathy would continue to be called membranous nephropathy. Renal tubular acidosis would be called renal tubular acidosis. The renal artery would be the renal artery. But we wouldn't be talking about renal insufficiency. We wouldn't be talking about renal impairment. Part 2 has to do with kidney failure. The KDIGO definition is GFR less than 15 or treatment with dialysis. Further specifications required. And terms to avoid would be a lot of terms that are very commonly used. Renal failure, ESRD, ESKD, renal disease, nephropathy, impairment, insufficiency, dysfunction, azotemia. This is in deference to avoiding using the term end stage. Part 3 has to do with acute kidney diseases and disorders, AKD and AKI. So it defines acute kidney diseases by the KDIGO definition that was listed before, and defines AKI as a subcategory of AKD. Part 4 has to do with chronic kidney diseases. These are the terms to avoid. And part 5 has to do with kidney measures. Now the glossary, I have 20 more slides for the glossary, but I think this is a good time to stop and open this up for questions. And I can show more slides as necessary.
That's great, thanks. Yeah, so I don't know if you've got a summary slide, but thank you very much. So I think...
Dear, I'm sorry. I do have a summary slide, I'm sorry. So just to have this on instead, here's the conceptual model for kidney disease. I'd summarize with this. Here is our slide for definitions of AKD and AKI. And here's the take-home messages for the glossary. Use kidney rather than renal, kidney failure rather than ESRD, the KDIGO definitions for AK, acute kidney disease, chronic kidney disease, and these measures. Let's leave this slide on while we talk.
Great. So I'm going to open it up for either questions in the chat, in the Q&A, or you can just turn your mic on and ask. And while people are unmuting or doing whatever, so you and I have chatted about this before, but there's obviously, whenever we introduce a new term, people roll their eyes and go, oh no, there they go again, those nomenclature people. I think the point that you're making, I guess maybe the point for all of us to think about is the precision that you talked about at the beginning that helps us to define, study, and give the right treatments is what I think the nomenclature discussion is really important for, as well as for patients, as you said. And I think that like the cardiologist went from heart failure to, you know, HFpEF and HFrEF and sort of started to further and further define things. So I think this is what the AKI, AKD, and CKD discussions are. I'd be curious, for some people, this may be the first you've heard of this, and wondering whether or not people have comments or thoughts or recognize the need for this, or...
I would add that people say, what's the matter with having multiple ways of describing something? Isn't that the richness of the English language? My comment would be that it's potentially confusing to have two different terms mean the same thing.
Right. Now, you have to raise your hand for Brenda to unmute you, but I'm just going to ask her to unmute all of you, just because it'll make it a little bit faster, just because of the how to manage this. Sorry, go ahead, Andy.
It's potentially confusing to use two terms to refer to the same thing. We don't know whether you mean the same thing when you use a different term. And if you've defined one term and you define the other term as meaning the same thing as the first term, then why do we need two terms? And remember, we have one language to talk about in medicine. Patients' charts are now visible to the patients. We want to let patients know about their illness. We want to communicate clearly, and therefore the language that we use in the charts really should mirror the language that we use in talking to the patients. We have to take account of different educational levels in our language with the patients. But why do we need to ask them to learn both English, Greek, and Latin terms for the same thing?
Great. I guess, you know, a lot of us have probably used the term AKI when really, in retrospect, it was AKD, right? And I think that our sloppy, like we've been a bit sloppy, and so we've used that AKI term as all-inclusive in the absence of AKD. in your experience, like in Boston, are people using the phrase AKD a lot more now, or is that still?
They use AKI for everything.
Right.
Even when it's not AKI. If the creatinine is up and 3 years ago it was normal, they say it's AKI.
Right. I'm going to be, so Brenda can't unmute you unless you raise your hand, because that's the way the attendees. So if you want to write your Q&As in, or else I'll call a name and she'll unmute you and then you'll have to talk. So Sunit, you always have thoughts on these things. So I'm going to ask if she's still on. Popped off. Is Sunit still on? No. I'm just trying to run the name of the attendees while I come down. I didn't realize that you have to.
I'd like to think that everyone agrees, but I know it's never that simple among our nephrology colleagues.
No, it's going to take, I think, I guess the most powerful stuff is our Albertan colleagues have thought about this as well, along with you, and have this data that demonstrates that it is a thing, and it does lead to different outcomes than if you don't have AKD. And perhaps that's one of the more compelling things. And our other colleague, Sam Silver, has spent a lot of time trying to think about how one follows people with, quote, AKI, which could have been AKD as well, and trying to establish that as an entity. So I think that is an important consideration as we navigate both with new medications that are available to delay progression of kidney diseases, as well as new nomenclature. I think it's kind of a different time in nephrology again, which is kind of exciting. I'm just trying to see if I can pick on someone who.
It seems like there's a question in the Q&A.
Yeah, if patients are reading charts, why keep the term renal artery and not change to kidney artery?
Great question. I guess we didn't want to bite off more than we could chew. We're not completely consistent in sticking to general terms rather than specific terms. I don't know that it's important to go all the way, but the point you raise is valid.
Okay. Someone else, could you clarify when it's appropriate to use the term kidney failure?
So kidney failure really was defined by the CKD guidelines. So it's appropriate to use the term when the GFR is less than 15 or for people who are on dialysis. It's not appropriate to use for people who have a transplant unless the GFR is less than 15. You can have a GFR less than 15 and be on dialysis because of AKI or even potentially AKD if it evolves slowly enough. And the Nomenclature Consensus Conference wasn't sure whether we wanted to go back to using the term acute kidney failure versus chronic kidney failure. So for the moment, kidney failure is defined for CKD, and for kidney failure, for a low GFR being on dialysis, for AKI, it's AKI stage 3. And we hope that our colleagues in the AKI field deal with this in their guideline update statement, because my particular feeling is I like using kidney failure in the acute setting as well, but we've traveled some distance to get people to think in terms of AKI, and it's hard to know whether we want them to go back. So I regard this as in flux still.
Great. And then there's another question about, I'll just read it in case you can't see it. Great overview. Any comments on age, such as pediatric, and so where does the pediatric world fit in to this nomenclature?
So the pediatric nomenclature always has a couple of different caveats for us. First of all, the GFR in children does not get to normal adult age until age 2, and then it's only when indexed for BSA. So before the age of 2, the GFR criteria for the definition of CKD don't really apply. Secondly, for children with congenital anomalies, of course, they're not acute, right? Even if they are born in extremis because of kidney failure. Those are the main areas where things don't fit well with pediatrics that always require some modification. Other than that, I think there was really widespread agreement that most of this applies to pediatrics.
Okay, so here we are, October 30th, and we have added a new, well, we have reaffirmed the new, a new approach or a new understanding of how to fill that gap between AKI and CKD. And so, you know, the provincial group of nephrologists that are on, and we started out, we had almost 50 people on the call today. It includes residents as well in internal medicine, as well as nephrology fellows and administrators and others and researchers that were on the line. And so hopefully this is the beginning of a new understanding and attention perhaps to a group of people who we haven't necessarily had a way to think about, and ideally then develop better management strategies and obviously treatment and outcomes. So thank you very much for taking the time to prepare the overview for us and take us through the history of where we were and where we're going to. Again, yes, it would have been lovely if you could travel here, but at least we got to reach 50 more people. So thank you very much.
Thank you. It's a lot quicker to get home from here.
Correct.
Bye-bye, everyone.
Bye.